Okay, so Dr. Langer is going to be joining us next. Shelby Langer is a personality and social psychologist, tenured associate professor in the Edson College of Nursing and Health Innovation at Arizona State. She's also a fellow of the Society of Behavioral Medicine. Her scholarship focuses on family processes within the context of chronic illness. Her work has spanned fairly disparate samples, including cancer survivors and their caregiving partners, children with GI disorders and their parents. Dr. Langer's primary line of investigation focuses on communication and emotion regulation among couples coping with late-stage cancer. Dr. Langer seeks to understand the intra and interpersonal consequences of patient and partner communicative behaviors and motivations on psychological, relationship, and physical health outcomes. Her work's been funded by the National Cancer Institute, National Institute for Child Health and Development, as well as the American Cancer Society. The talk she'll be giving today, the relationship intimacy model of couple adaptation to cancer, support from a prospective longitudinal smartphone-enabled ecological momentary assessment study. Dr. Langer's colleagues include Michael Todd, research professor at Arizona State, as well as Laura Porter, a professor at Duke University. So as we're handing things over to Dr. Langer, just a reminder, please feel free to submit questions through the Q&A option there at the bottom of your screen. So welcome, Dr. Langer. Thanks so much for joining us, and we look forward to hearing more about your work.
Okay, hi, happy to be with you all. Let me see if I can get this started. And is that showing the full screen?
That's it. Looks
okay. Good. Okay, great. Again, happy to be here. I want to commence by acknowledging my collaborators, and I'll be presenting data from a multi-site, multiple principal investigator grant awarded to myself and Laura Porter at Duke University. And I also want to call attention to Mike Todd, who's an ASU colleague and our statistician. So this work was funded by the National Cancer Institute. And the title of our larger project is Couple Communication in Cancer, a multi-method approach. That was implied by that title. We look at communication among couples coping with cancer in a number of different ways. So through traditional global self-report measures, surveys using REDCap over the course, quarterly over the course of a year, through observation of conversations in a lab-based setting, and then in the lower right, through smartphone-based ecological momentary assessment. And as you might guess, given the theme of today's conference, I'll be focusing on the latter. So I believe there's about 14 million cancer survivors in the United States right now. And as we know from a great deal of clinical research that the experience of cancer diagnosis, treatment is quite challenging, as evidenced by the impacts listed on this slide. And it's by no means an exhaustive list. And just to kind of convey that concerns range from the pragmatic employment disruptions to the existential fear of cancer recurrence and even death. A number of these patients will require support from an informal caregiver. It's typically a family member. We're focusing here on caregivers who are spouses or partners. And so what do these folks do? A lot. They serve as sort of translators to the medical team, provide medical assistance, manage symptoms, provide emotional support, and help with activities of daily living. So given all that, it's not surprising that caregivers have their own impacts or sequelae, if you will. So depression, anxiety, fatigue, sleep disturbance, and in some cases, marital dissatisfaction. We know that from a pretty big literature on dyadic coping, that the couple's ability to communicate effectively about the cancer experience plays a major role in their psychological and relationship well-being, or their adjustment to the cancer experience. And communicative behaviors can be categorized, broadly defined, as relationship enhancing or compromising. So on the left, we have disclosure, the open sharing of thoughts and feelings about cancer-related concerns, and then in turn, supportive listening, responsiveness, empathy. And then on the flip side, these more avoidant behaviors, so holding back from disclosure, kind of this hesitancy to share. And then a similar construct called protective buffering, which is defined as hiding concerns, denying worries, concealing discouraging information, and yielding in order to avoid disagreement. And while that definition implies this sort of pro-social intent to protect the other, what we find, in fact, is that holding back and protective buffering have deleterious consequences. So they're associated with increased distress and decreased relationship satisfaction among both patients and partners. And these effects are both intrapersonal, and that the person who buffers reports more distress, but also interpersonal, and that the object of that buffering, the buffee, if you will, also reports increased distress. So we know that this linkage exists. What we know less about is mechanisms by which communication is linked to adjustment to the cancer experience. There's been some conceptual models that have been advanced. I'm going to focus here today on the relationship intimacy model of adaptation to cancer. And the thinking here is that by sharing thoughts and feelings with a significant other who is responsive and they're listening, that leads to increased feelings of intimacy in the relationship. So, and by that I mean closeness or connectedness. That in turn leads to better psychological and relationship adjustment. So research to date designed to test this model or parts of it has tended to be cross-sectional in design, involve samples that were lower stage disease, gender specific cancer, so breast cancer, prostate cancer. And what can happen there is with opposite sex couples, you get into a situation where gender and role are confounded. So you've got all, in the case of breast cancer, say all female patients and mostly male caregivers. And these studies have also relied on global self-report measures of communication, which require retrospection. And there have been some daily diary studies, but they typically either have folks go to, say, access a website at a certain time of day to answer questions, or to use a study-provided electronic device. So I would argue that's not quite the same as taking advantage of participants' own smartphones that tend to be, close at hand in their back pocket, probably too close at hand, we can attest to. So advantages of EMA, this is, I can spend about 2 seconds on this because I'm preaching to the choir, but it affords the assessment of events and experiences in naturalistic context and in real time, and it also allows us to look at temporal processes. All right, so methods of our study. Here are the inclusion criteria for patients. They were adults, stage 2 to 4, breast, colon, rectal, or lung cancer, currently receiving or having received chemotherapy or hormone therapy, within 2 years of diagnosis, married or in this committed, and that was self-defined, cohabiting relationship, able to speak and comprehend English, and then the partners had to be the first and the last, so adults, and then also English speaking and comprehending. So we sought to examine key constructs of the relationship intimacy model as couples went about their day, so in real time and in their naturalistic setting. And to do so, we developed an app, there's an app for that, using the LifeData platform. So patients and caregivers were independently prompted twice a day at 12 p.m. and then at 8 p.m. And this lasted for 2 weeks of 14 days. And at each prompt, they were asked to say whether or not they talked with their partner, either since awakening for the afternoon assessment or since the last assessment for the evening assessment. And then if yes, a series of questions followed. So they were asked to rate the extent to which the conversation had been about the cancer on a 1 to 5 scale. They were also asked to rate the perceived importance of the conversation. And then a number of items to assess communicative patterns or their own behavior perceptions of their partner in that conversation. We asked several items. I'm just going to talk about 2 today. One was the extent to which you expressed your feelings during this conversation, 1 to 5 scale. That we're calling that disclosure, and then the extent to which you held back from expressing your feelings. So that was our predictor in the model. And then intimacy was the hypothesized mediator. This was assessed, it was an aggregate assessed with 2 items. How close do you feel to your partner right now? And how connected do you feel to your partner right now? Again, 1 to 5 scale. And then we had 2 outcomes, separate models. One was distress, so 9 items from the profile of mood states, the anger, anxiety, and depressed affect subscales aggregated. So how anxious do you feel right now? And then to assess relationship satisfaction, we used a single item, item number 31, if you're familiar, from the dyadic adjustment scale, which I would argue is a gold standard measure of relationship adjustment. And so they're asked on the 7-point scale to rate the happiness of their relationship that day. So I think I said that these prompts were happening twice a day for 2 weeks. This is the one item that we just asked in the evening. We wanted to minimize burden, and just had a hunch that this would be more stable, certainly within a day. And in fact, the data bore that out. So just in the evening. All right, so we used multi-level structural equation path models with an actor-partner mediation framework to examine both intra and interpersonal associations among our hypothesized predictors, mediators, and outcomes. So with respect to the time frame, we were looking at afternoon communication, so that was either disclosure or holding back, as a predictor of that same day evening adjustment, so that was either distress or relationship satisfaction, separate models, through intimacy that afternoon. All right, so results. Here are baseline demographic characteristics of the sample. I'll be presenting data from 232 couples, and that's what we had when at the time we pulled these data for analysis. We've got about 317 now, I believe, couples. So folks were on average age 53, gender distribution, 68% female patients, 34% female caregivers, mostly white, non-Hispanic, about 60-ish%, 61 to 67% had earned a college degree. And then we assessed length of relationship categorically. This was done at the first EMA prompt. And I just want to point out that 69% of the sample had been together for at least 15 years. Type of cancer, we've got more breast and colorectal, and that's in part because we added lung about 2 years into the study to expand. Cancer stage within type. So what I want to point out here is we have more early stage breast cancer cases and more later stage lung and colorectal cancer cases. Okay, so the fun part, smartphone data completion. And so among about 13,000 notifications sent, this is across patients and partners, this is across the 28 different assessments, 88% of those notifications were responded to and 87% were completed. And we were just thrilled with that. You know, many of these patients, just as we engage with them, are quite ill. So they're taking a lot on, and just really continually amazed that they're willing to do this. So here we have the same data separated out for the afternoon and evening prompts. And so the completion rates are similar. One thing in heading into the study, we wondered about the base rates of conversations. You know, would there be a conversation that they would be able to then make judgments about? So at the afternoon prompt, which would have been, you know, a morning conversation or something up until noon, 81% of those prompts were characterized by a response saying that they had conversed with their partner. So it's the majority. And then, you know, that was higher in the evening, so 88%, which makes sense. They would have had a chance to have dinner together, presumably. And then with respect to their perceived importance of the conversation, I would say moderately important. So again, this is a 1 to 5 scale, about 3.2. And then to what extent the conversation was related to the cancer, this 2 is on a 1 to 5 scale. Not so much. And so that was interesting to us, and sort of good news. Life goes on, there's other issues that they're talking about. All right, so before getting to the mediation results, I want to set the stage here. This is a theoretical slide, and it shows you the paths of interest. And we've got, and let me just, for those unfamiliar with the actor-partner interdependence model nomenclature, a quick primer. So actor effects are within person or intrapersonal. So if I disclose, I feel more, or I report more intimacy. Partner effects are interpersonal. So if I disclose, my partner reports more intimacy. So we've got here 2 actor-actor indirect effects. That's the red line and the blue line. So I'll just walk you through, for example, if the red line were to be significant, we'd be looking at afternoon patient disclosure to that same day evening patient relationship satisfaction through intimacy. So completely intrapersonal effect. Same for caregivers with the blue line. The other effects are partner actor indirect effects. And so here, let's just look at the green line. This would allow us to look at afternoon caregiver disclosure, predicting patient relationship satisfaction through patient intimacy. So hopefully this will be a little clearer as we move forward. All right, so starting with analyses that treated disclosure as a predictor, intimacy, of course, is always our mediator, and then distress as the criterion. And I'm only going to show you the significant paths. So here we have two actor indirect effects, one for patients, one for caregivers. Again, let's look at the red line. So on afternoons when patients disclosed, this was associated with their own greater intimacy at that same time point, and then which in turn was associated with less distress that evening. And then similar pattern for caregivers. Okay, here we're swapping out the criterion. So again, just two actor indirect effects. And again, we'll look at the red line. So on afternoons when patients disclosed, they reported more intimacy at that same time. And then this led to greater satisfaction that evening. Similar effect for caregivers, again, but all intrapersonal effects. Okay, moving to holding back now as our predictor, intimacy as the mediator, distress as the outcome. So here, again, we have two actor indirect effects. I'll start with the red line. So on afternoons when patients held back, they reported less intimacy at that same time, and that lower intimacy was associated with greater distress. So this is an inverse association here, or conversely, higher intimacy, less distress that evening. And then, so similar effect for caregivers. And then we also got a partner actor indirect effect. So on afternoons when caregivers held back, their patient, their partner, reported less intimacy at that same time, and that lower intimacy was associated with greater distress that evening. Right, and then the last model, holding back to satisfaction through intimacy. So here, all of the indirect effects of interest were significant. I'm going to try to sum this up in a sentence. On afternoons when patients held back, when both patients and caregivers held back, they reported less intimacy, as did their partners. And less intimacy that afternoon, in turn, was associated with lower ratings of one's own satisfaction that afternoon. So the B path, if you will, is it's a positive association. So greater intimacy, greater satisfaction, or lower intimacy, less satisfaction. Okay, so to conclude, good completion rate, again, we were quite thrilled with that. And then I think support we can conclude for the relationship intimacy model. And to sort of dumb it down here, disclosure had intrapersonal benefits. So that was, you know, when folks disclose, they had greater intimacy, and then less distress and greater relationship satisfaction later that day. And then holding back had both intra and interpersonal detriments. So I think, to me, it's interesting that because holding back had these partner effects, to me it suggests that the name implies sort of this blank slate or poker face, if you will, but there's something about holding back that must be observable to the partner. We know that suppression is associated with physiological arousal. So I think this really merits a lot more attention to see what is the behavioral manifestation of holding back. What does that look like? So implications, you know, it makes sense that we might design interventions to facilitate disclosure, reduce holding back, boost intimacy. These things are warranted. And much of, you know, we're already conducting these sorts of couple-based interventions. They tend to focus on disclosure, teaching these, you know, basic communication skills, disclosure, effective listening, which is harder to teach. But I think holding back merits attention, and that piece may not be best done dyadically. So it's possible we may must start, especially with caregivers, given the findings, to work with them, perhaps one-on-one with an interventionist, to identify ways in which they might be avoiding motivations for such, and then perhaps move to the dyadic piece. All conjecture, you know, that this merits empirical testing. And then I think, as anyone probably joining us today can appreciate, one thing we found is that, or sort of need to consider, is that repeated assessment prompts introspection. So here's just a couple of quotes that we got from our participants. So I appreciate how it has prompted feelings and attention to some gaps in our conversations. We took the opportunity to have an important conversation. So, we're trying to get at naturalistic behavior, but we may be shifting their behavior by causing that awareness. And there are a couple of mostly positive quotes like this, but a couple of negative. Gosh, it made me kind of think about the cancer. All right, and limitations. So this was not the strongest test of mediation because the mediator was assessed contemporaneously with the predictor, and analyses were limited to same day effects. So we're working now on a new set of analyses where we'll look at evening communication to next day afternoon intimacy to that same next day outcomes. And so more to come. And I will stop talking. Thank you, thank you, thank you.
Okay, thank you very much, Dr. Langer. I'll get video started here. Really appreciated your talk, and also thanks for dumbing down the analyses a little bit. There's a lot going on there, so your visual representation was really, really helpful. As we get started here, I guess maybe a comment, and I'll invite your reflection. One of the things I think your study demonstrates is the value of testing theoretical models using this kind of EMA approach, and the ways that you were able to then sort of disentangle what was happening relative to cross-sectional designs. So I really appreciated that about your study. Can you say just a little more about kind of where you see this work going? I appreciated some of the implications that you shared, but where do you plan to take this next?
Well, right. When we wrote the grant, we tried to sell the translational potential. And I mean, I should say we're testing two models with the grant, and the other is a social cognitive processing model. So, and the thinking there is that by sharing thoughts and feelings, you're processing the trauma, if you will, in this case, cancer, which leads to better assimilation and accommodation of the, into memory of the cancer experience. And that in turn will lead to better adjustment. That may be more individual or intrapersonal. That may not need couple-based intervention. So I think we're trying to get to a point where it's to figure out some tailored and targeted approaches. So what might be best just done one-on-one with an interventionist versus with the couple together. And I think also that this EMA, was so successful, just in terms of our completion rate and ability to extract information this way. That could certainly, I'd love to look at this as predictors of clinical outcomes, morbidity, mortality. We see that it's this kind of quick and dirty way, if you will, of getting information that really could be predictive. So we'll be able to look at these indicators of communication and the other pieces of the model, predicting adjustment a year later on the questionnaires. So lots of, I guess, different angles, and not sure yet.
Great. We had a question here. It says, well, first, thank you for a wonderful and clear presentation, Dr. Langer, and goes on. In terms of next steps with EMA data, what are your thoughts of a next study where participants are also asked about the content of their conversations, and how content is associated with communication behaviors, intimacy, satisfaction, and distress?
Yes, all that. So we, both in piloting this and then designing the app, we really wrestled with, do we want to get at what they were talking about? And we toyed with some categorical items, like a drop-down menu to categorize what conversations might be about. And we just decided that maybe it doesn't matter because anything could be loaded. You could be talking about what you're going to do next week, but that's actually related to the cancer because you can't plan ahead. So we wrestled with that, and I took it out just because of time constraints, but that was going to be one of my limitations, is that I can't tell you what they were talking about. But we do have the perceived importance and the cancer relatedness. Now, so as I showed, it was not frequently related to the cancer. So we could, look at that as a moderator, or do some additional analyses to does perceived importance matter. And certainly, if something's important to you and you're being constrained from sharing it, then that's going to have more of a deleterious effect. So I think great question, and welcome thoughts on how to do that with the app or how to
Sure,
expand.
sure. Okay. Another question here. Have you thought about doing analyses to see whether holding back and sharing changed over time or with number of responses?
Excellent idea. I should be writing this down. I'll try to remember. We have, not within the EMA. I think that's a really, and also this point about did it shift them? Did this awareness kind of change their behavior? So I think it's a great question. I believe we did find in the pilot that these things are more variable within person than between. So all of the communication variables. Whereas relationship satisfaction was more, that varied more between people than within folks.
Okay, okay, great. Thank you. Thank you. Looking to see if we have any other questions. We've got a break, announcement coming up with Kevin here in a minute. Let me say thanks again, Dr. Langer, for your presentation. Really appreciated that, and wish you well as you wrap up. I noticed you mentioned 300 and some participants. What's your final number you're aiming for? Because that's a pretty substantial study.
Well, we told NIH 434 couples, but COVID-19 is, we're still getting this part where we're doing the online stuff, but the lab-based couple conversations are stalled right now. So we'll see.
Sure. Okay. Well, we do wish you well, and thanks again for a great presentation. I'm going to hand things off to Kevin here, and as I mentioned, at around 3:45 we'll get started with the next talk. But let me hand things off to Kevin.